Great, thank you. Great talk, Dr. Saab. There was a lot in what just Dr. Saab mentioned that you will see the lessons of that applied in the cases coming up. And the first one is this one here. So here's a patient, a 61-year-old younger person, 3-week history of worsening pain and coolness. When he presented to ER, he was actually still motor and sensory functions were intact, but he was in quite a bit of pain. Past medical history, AFib, diabetes, no history of claudication before 3 weeks. And so here's the angiogram on the left side. So you can see that the SFA is gone, and here's the SFA coming back in. And here's what it looks like. Now, first question is, all right, where did the clot come from? Of course, you look at the history, you say AFib, okay, probably AFib. Most of these guys, I mean, he's lucky that he didn't have a stroke. I can tell you most of our patients with the AFib, with the embolize, we're treating him for a stroke. This is probably AFib, okay, it's possible, but also look at the history, 3 weeks, right? So this is not something that happened just acutely recently. The other key finding here is that, as you can notice, the profunda is gone also. So that tells you that this was a distal embolization, an embolization case rather than in situ thrombosis or plaque rupture or an underlying lesion. Look at the rest of the blood vessels. They look pretty good. So right there and then it tells, you know, initially when we see something like this, we think, okay, but there's an underlying lesion probably there, and as you cross, we want to make sure interluminal, things of that sort. The other thing is if you pass a wire and it crosses easily, think that there may be fresh thrombus in there. That you don't bring balloons out, the next thing you do. So the same thing happened here. We passed the wire and it easily crossed. So immediately you know, both by history, the fact that the profunda is gone, and the fact that the wire passed easily through, that there is clot in there. Look down below. In the popliteal artery, sort of filling defect setting where the arrows are at the trifurcation, there's some clot. Now down below we have good vessels, but as you can see, embolus to the anterior tibial artery, actually dorsalis pedis, right? So we have multi-level emboli in here. So the approach is going to be interesting. How do you do this? And I can tell you that the first thing we do in these situations, especially for those distal clots, we start aspiration thrombectomy. As opposed to many other things that you may want to treat distal to proximal, we treat these proximal to distal. As you can see, trifurcation is already occluded. During thrombectomy of the proximal segments, if you embolize distally, you're already protected because it's occluded already. Now, there are other techniques you could use to minimize distal emboli, you know, pressure cuff, distal embolization, distal protection, things of that sort. But if you have a lesion down there, it's already occluded, right there you're fine. So we started thrombectomy. 088 catheters, and these are, you know, pretty common. And this is after passes. You can see we cleaned out the popliteal and the trifurcation, so we have some flow going there. Now you see some underlying disease, but look at the proximal SFA. That doesn't look very good. And so then profunda is still, of course, occluded. We would do that at the end. A few more passes of thrombectomy, large bore thrombectomy devices, and we still have what I call sausages in there. These things, especially if they start getting organized in the lung, they're not coming out with aspiration. Doesn't matter what size you use. You're not going to put an 8 French or a 10 French or 12 French in an artery for that. We have better solutions than doing that. So at this point, we moved on to Pounce. And here's more stuff down below, as you can see, all right? But a little bit better. We got flow, foot warmed up, but you're not going to leave that alone. So here's a Pounce deployed, as you can see. We pulled it down from the SFA. He's just about going up in the upper, coming to the origin of the profunda. Now, as you can see, the funnel is deployed above profunda. Now, we don't do that if profunda is patent. You don't want to drag that clot especially if there's antegrade flow across profunda. You want to deploy the funnel below the profunda, clean the stuff below that. Now, if you have something above it, then you can do this technique. The reason we did that from the beginning is, you know, profunda was out to begin with. We had clot in there, and we would go after that at the end. We now have to establish, get the foot warm. Once we do that, then you deploy either the same technique or aspiration into the profunda and get that clean. One of the cases that you saw in Dr. Saab was that brachial artery. Great device for brachial artery and occlusion. Make sure you deploy the profunda, the funnel distal to the vert. Okay, but just absolutely make sure that's a non-starter, non-negotiable thing. Can't put that proximal to the vert. Let's go back. And here it is after the Pounce thrombectomy system. It was used in the SFA as we showed you. The other ones were cleared with aspiration, including profunda. I was actually prepared to use the Pounce and the profunda also, but first aspiration, the clot came out. Here's the IVUS. On the left side in the SFA, completely occluded. Now, sometimes if I'm going through a longer segment, which I think is clot in there, and I'm not sure whether I was entirely intraluminal, it's good to put an IVUS in there to make sure that before you do any other maneuvers that you are intraluminal. But you can see it's all clot. But look at that second IVUS to the right. That's after aspiration thrombectomy. Now, we had good flow. You guys saw the angiogram. Now, if we hadn't done multi-projectional angiogram or IVUS, you may in certain projections think you got good flow and you're done. But you would leave all that junk inside, which will embolize a couple of hours later. And then here it is after Pounce. That this is before and after Pounce, before Pounce, after suction thrombectomy, and Pounce on the other side. And here's the stuff down below that cleaned out.